Welcome to iCubed episode number 42. This is August iCubed episode. Thank you everybody for following me all these months. I really appreciate your support. Now, over the past 4 to 6 months, the entire world has been beset by this pandemic. And it's just been a horrible, horrible situation, and it's just kind of upended everybody in the world. Now, if there's a good thing that could be said about this pandemic is that it's really emphasized the utility and power of foam ED, right? And so you guys know how excited I get when I have special guests, right? I really hit the jackpot today. I have two, not just one, 2 special guests. Oh my gosh, they are like my favorite foam educators out there. So Salim Rezaie was a guest of ours a few months ago. Hi, Sal. Welcome.
Hey, how's it going?
And then I have a second foam educator, star, Dr. Anand Swaminathan. Swami, nice to meet you. Welcome to
good
iCubed.
to meet you too. Thanks for having me on. I really appreciate it.
All right. So I am actually a little starstruck today, so you don't mind if I stumble over my words. So I'm going to ask, Sal, where did you study and where did you get your training?
Yeah, I went to medical school at Texas A&M. I trained at Temple Scott and White, and then I decided that I didn't know what I wanted to do with my life. So instead of doing one residency, I decided to do 2 residencies at the same time. Swami likes to say that I just needed the extra 2 years to be able to practice as a competent physician. So I went to East Carolina University and I did an emergency medicine, internal medicine combined program. And then ultimately I've now ended up in San Antonio, Texas, which is where I currently practice.
That's wonderful. And Swami?
So I did medical school in New Jersey, in Newark. What was used to be called UMDNJ, New Jersey Medical School, no longer exists. It's now Rutgers, New Jersey Medical School. But I was told very clearly, I'm not supposed to say that I graduated from Rutgers because I didn't. And then I did residency at NYU Bellevue, which is in New York City. And whenever Salim and I get to do podcasts, I always feel inferior because he's double boarded. I'm only single boarded. So I'm going to go back and I'm going to get 2 more board certifications just so I can hold it over him.
Wonderful. Well, you guys have been wonderful to follow. You've done such great work. Just leading us, pit dogs, the everyday community emergency physicians like myself. So let's just start the case, all right? So when I emailed you guys about this case, I really didn't want to give it away too much. So I just said, the hint was a 21-year-old female with abdominal pain, right? So you've got, I'm sure, this wonderfully long list of differentials at that point, right, when you hear that. Now, what really happened was the triage nurse says, she's a 21-year-old female, G3P1011, with severe abdominal pain that's been happening every 90 seconds for the past 2 hours. So your differential probably narrows down to very, very little, right?
I mean, my differential right now is it's COVID-19. Is that
everything's COVID-19?
I wouldn't disagree with you at all, actually. All right. So then a little bit more history. There's no vaginal bleeding. There's no gush of fluid. She's had a little bit of prenatal care with one of the local OBs that I know early on in her pregnancy. So based on her EDC, she's roughly 31 weeks, 2 days, okay? Her last pregnancy resulted in an emergency C-section, and it was due to a prolapsed umbilical cord. And to top it all, ta-da! She admits to using methamphetamines 3 hours ago. You've never seen that, have you?
What's this meth you speak of?
So, I go into the room along with the staff and, just on a quick exam. She's obviously in late term, pregnant young lady. She's scared and she's crying. She's sitting on the bed on the gurney. Her vital signs are the following. Blood pressure is 124/72. Her heart rate is 117. Her respirators are 20 and sats are 99% on 2 liters nasal cannula. So now what, Salim? I'm going to pick on you first.
No, it's fine. I'd like to hear a little more about the her previous deliveries. I mean, I think this is where like the art of medicine is like history and physical, and so I'd like to get a little more information about previous pregnancies, if she's had any issues. I know you talked about the prolapsed cord in the last one, but has she had any other major problems? And then when was her last OB follow up? Like, are we
Right.
talking she had first trimester like ultrasound imaging, or are we talking like she had something, more recent? I think this kind of changes your thinking a little bit. And then, anytime you have a pregnant patient who's complaining of lower abdominal pain, um, we don't have to get into the whole pelvic exam, no pelvic exam, but I think in this case, like that's one of the things you're thinking about an obstetric
Right.
emergency. And
Right.
so I would say that this is one of the times that doing a pelvic exam is probably warranted because, an ultrasound will give you some information, but I think the pelvic will give you a little bit more.
We need that nice practical approach, right? Because this patient, most of the places that I work, we have OB in-house 24 hours a day. So I would never even see this patient. This patient would be whisked upstairs to my labor and delivery services, but I do work in some smaller community places where we don't have it. And so what I need to decide is this patient stable enough to be transferred, or
Right.
do I need to do this delivery? And so the
Right.
things that I think we're going to do right away are, of course, the things we always do in emergency medicine: airway, breathing, circulation, get some IV access. I don't necessarily know that I need any blood work. I definitely want my ultrasound at the bedside. And then most of the places that I've worked, we usually defer the pelvic examination because doing a sterile pelvic in the ED isn't always easy. But if you don't have OB in house, you need to do some kind of an exam. You definitely need to take a look and make sure that the head isn't already out, regardless of what she says about bleeding or a gush of fluid. I don't trust anybody. None of us trust anyone. So you got to at least look and say,
Right.
is the head at the perineum? If I see scalp, I already know where I am. I'm going to have to deliver this baby. If I don't, then I think you probably need to do a sterile spec exam to know, is the cervix massively dilated and this is inevitable pregnancy that you're going to have to deal with? Or do you have a little bit of time and perhaps you can actually transfer that patient somewhere with obstetric capabilities, because this is a complex delivery.
Yeah.
Previous cesarean section makes you think about things like uterine windows, where the muscle is a little bit thin, and those patients can get uterine rupture. She's got methamphetamine on board, which her vital signs aren't that bad for methamphetamine, right? I mean, having a tachycardia of 117 while you're in active labor, I'm going to give that one. I'm going to allow for that, right? So her vital signs aren't that bad, but there's meth in her system, so that makes it complicated.
Yeah.
And then, of course, even though there's no bleeding, we're worrying about abruption, and we're worried about previa. She's got a previous prolapsed cord. There's so many different problems here that, if possible, I would like to send her to a place with specialty care.
Right.
But that decision is really going to be based on that sterile pelvic. So we gotta get down there and see what's going on.
That's right.
The other thing I would add to that is I think oftentimes, you hear meth and you hear lower abdominal pain. And so you start thinking about preterm labor. But I also think this is not a time for anchoring and quick diagnostic closure, because there's lots of things in the lower abdomen that can cause this type of discomfort. But I think in terms of triaging and priority, that's the one thing we want to make sure that we're ruling out or ruling in and getting ready for. So that'd be the only other piece I would add to that.
Right.
And then I think the other thing, Salim and Alice, that is going through my head is equipment. What equipment do I need at the bedside?
Absolutely.
So I want a baby warmer, because maybe this is going to be an inevitable delivery. So I want my neonatal kit and a baby warmer. And if you're not in a place that does a lot of deliveries, which for instance is my emergency department, where we do almost none because they all get upstairs,
Right.
knowing where the baby warmer is, getting the baby warmer plugged in, finding really your triage nurse or your charge nurse, because they know everything. Let's be honest. They know how to use all the equipment. They know where all the equipment's hidden. So get the baby warmer out, get it plugged in, get all your neonatal equipment ready. 31 weeks, that could be even more premature. So you want to make sure, you might have to resuscitate the baby. If you've got a colleague, you're going to need a second team. You can't both deliver and resuscitate a baby. So get your help in the room.
Absolutely.
I mean, all hands on deck. Get any help you can. Even if you're in a community place, you might have a general surgeon on call in the emergency department. Get them in. My dad is a general surgeon. He retired a couple of years ago. He tells me how many deliveries he's done, both cesarean section and regular vaginal deliveries. Get that guy in. That's the guy or gal you need at the bedside to help you. So if you have that, call them. Call your transfer hospital. We know how long that takes.
Yep.
And then I'm going to want airway equipment at the bedside too, and those kind of things. But thinking about all that equipment that you need and getting it out up front, getting things ready to go, really critically important.
Yeah. So that's fabulous, Swami. Now, my hospital actually got rid of their OB services about 5 years ago. Of course.
5 years too early.
Yeah, exactly. So having a delivery imminent in the emergency department is one of the most stressful, anxiety-provoking situations for any emergency physician, especially someone who hasn't done a delivery for probably 20 years, right? When this woman came into the emergency department, I was, to say the least, very nervous about what was going to go down here. So the first thing I did, other than talking to her and looking at her and just making sure her vitals were okay, was to perform a focused OB exam, right? So, and when I did all I did was have her lay on the bed, and I did a bimanual, and I go, and I'm like, oh my goodness, she is 100% effaced and 10 centimeters fully dilated. But then I'm feeling this bouncy amniotic sac still fully intact. And I thank the Lord under my breath. I'm like, okay, her water's not broken. She didn't break the amniotic sac. So I have a little bit of time to deal with this, right? So I, of course, had the nurse had her get her on the monitor. I had the IV started. I brought the bedside ultrasound because I wanted to know where the head of this baby was for sure. I can feel the head of the baby, but I want to know where the head of the baby was. And was there more than one in there? I was able to determine there was one head, and it was down in the pelvis. So that really alleviated a lot of my concern at the time. So, folks, everybody knows by now, I think, that I have 2 learning focuses for every episode, because I just want to, if I can, boil it down to the most important points. Now, I want to teach two points that I think are very important out of this particular case, okay? So the first one's, the baby is coming, the precipitous delivery. And so in my research, I read a few very, really, really excellent articles. Here's one of the Emergency Department Management of Precipitous Delivery and Neonatal Resuscitation. And then this is another blog I read often. It's First 10 EM. And then Up to Date I use very often as well. Precipitous birth not occurring in a labor and delivery unit. And then in Medscape, this was a terrific sort of a slideshow post talking about best practices in delivery in the emergency department. So with the precipitous delivery, first off, the definition means rapid labor lasting for less than 3 hours. Less than 3% of deliveries in the U.S. occur this way. And it's oftentimes commonly triggered by chorioamnionitis, hypertension, or illicit drug abuse, like this young lady. Other causes for precipitous delivery are trauma, maternal cardiac arrest. Oftentimes, there is little or no prenatal care. All right. And then they are more likely to have preterm or high-risk neonates, right? Just a few things to really remember in the moment, which is you try to obtain a bedside ultrasound like I did, just to see if there's only one pregnancy, to see what the presentation of the baby is. So unless there is vaginal bleeding, go ahead and perform a manual vaginal exam. If the patient is fully effaced and dilated to 10 centimeters, birth is imminent. Now, what does imminent mean? That's kind of a little vague. It could be in the next hour or less, right? But the reassuring thing, even with precipitous deliveries, most of them occur normally. I don't know how often you guys deliver babies, but we don't do this very often in the emergency department, in a geriatrics emergency department, okay? And so as you know, you can guesstimate the age of the baby by the fundal height, right? So 12 weeks at just above the pubic bone, at 20 weeks is at the umbilicus, and then 36 weeks gestational age is right up against the sternum. So all of the next few slides are going to happen within minutes to, longer, but just quickly going through that, once the baby is crowning, make sure to support the perineum because that will lessen the chances of a tear. Just apply some gentle pressure on the occiput of the baby. Allow the rotation of the head naturally once the head is delivered. Check for the nuchal cord at this point. When the head is delivered, make sure that there's no nuchal cord. And if the nuchal cord is loose, you can just kind of swing it over the head. If it's tight, though, it's recommended that you put 2 clamps and then cut. Once you've delivered the head and once there's no nuchal cord, then apply gentle, steady downward traction and deliver the anterior shoulder, but be sure not to pull hard or yank the head because that would possibly cause brachial plexus injury. And then just recognize what this is, a turtle sign of shoulder dystocia. That is to say, when you assist the head out a little bit and it retracts, then you've got to be suspicious of the shoulder being stuck behind the pubic symphysis, all right? And then once you deliver the anterior shoulder, apply gentle, steady upward traction to deliver the posterior shoulder, at which point be extra careful. Don't drop the baby. Don't drop the baby because now the baby's going to slide right out of there, okay? Then once you deliver the baby, put the baby on the mom's belly, and it used to be routinely recommended that you suction the baby's nose and mouth once the baby's delivered. That's no longer routinely recommended. So then once you have the baby on the belly, mom's belly, cut the umbilical cord, and then I always have to have the nurses take care of the rest of this, have them do the APGAR score, right? Then you've got the baby out. The next step is to apply gentle traction to this umbilical cord and then allow for spontaneous delivery of the placenta. Be very gentle. Apply a little bit of pressure over the suprapubic symphysis there, and that would prevent the uterus from inverting as you're pulling traction against the uterus. And then the very last thing, after you deliver the placenta, gently massage the fundus to help it to contract and also give a dose of oxytocin, 10 units IM. Just remember that most of these will deliver just fine naturally. The most important thing, I think, is to really control the expulsion of the head by putting a towel on by the perineum, and that would minimize any perineal tears.
Can I say 2 things before we go on to the second teaching point? Okay. So the first thing is this is a really scary thing because it's not something we do commonly, but there's lots of other procedures in emergency medicine that we get trained for that we don't do that often, like lateral canthotomy or ED thoracotomy. There's lots of them that are out there. And the one point I want to make is that, and Swami is great about this, is that if there are procedures that you think you would be scared of doing in real time, you're probably going to not do as well at it unless you practice and you go through those steps and you read up on it and you watch the videos and you try and get a lot of the kind of tactile sense of what it is that you're doing. And so this is something a lot of us do, is these procedures, we don't do that often. We're practicing them so that when the real time comes, we're able to do it. The second thing I would say is that not every system is going to be exactly the same. So for example, some of the emergency departments I work at are what we call standalone emergency departments, which is basically an ER that's not attached to a hospital. Right. So if this patient would come to me in one of those facilities, it's all on me. Yeah. There's no backup. There's no partner to come help me out. It's me and 3 nurses and a janitor. And so it's important to, do these things for the people like, that work in the ivory towers and can send these patients to the OB floor. That's great. But I would argue that most of us, we're not in the ivory towers. We're out in the community. And so it's important to keep up with these procedures.
All right. So learning focus number 2. Oh no, it's stuck. This article from EM Docs is fantastic. So this post basically explains 3 different complicated deliveries and what to do about them. So number 1, shoulder dystocia. Number 2, breech presentations. And number 3, prolapsed umbilical cord. So we're going to go through this relatively quickly, but I'm going to mostly concentrate on the shoulder dystocia. So there are all these maneuvers. Have you heard of any of these?
There is some data on this stuff, and McRoberts works the vast majority of the time with
Right.
shoulder dystocia. And I think that's really helpful to know if you're going to remember just one of these. McRoberts is probably the one. But the Woods and the reverse Woods are also extremely useful, and I've used those a couple of times in shoulder dystocia as well.
Wonderful. Well, when I look at a list like this, my head goes like that. It spins. I can't remember names. I don't know what. So I don't know if you are, but I'm very much a visual learner. Are you guys visual learners? I definitely am. So I was able to find this clip on YouTube, and I just want us to go ahead and watch. It's only a few minutes, but it goes through all these different procedures in a visual manner, and it really completely sort of lit my brain up. I'm like, oh, now I understand, because reading about these procedures was very difficult to understand.
This is the McRoberts maneuver. You want to flex the mother's thighs as high as you can onto her abdomen. Apply suprapubic pressure. You want to have a CPR-style hand position and apply pressure to the posterior aspect of the baby's anterior shoulder. This should be with a rocking motion. This maneuver should be attempted for about 30 seconds, as with the other maneuvers. What you're attempting to do is to actually move the baby's shoulder anteriorly on the thorax, thereby decreasing the bisacromial diameter. In the Rubin maneuver, you want to place 2 fingers from one hand behind the baby's anterior shoulder and attempt to rotate it forward, thereby rotating the baby through the pelvis. What you're attempting to do is to rotate the baby's shoulder anteriorly, like this. Next maneuver is a wood screw. So you still have your 2 fingers posterior or behind the anterior shoulder. You then attempt to take 2 fingers from the other hand, place them anterior to the posterior shoulder or in front of the posterior shoulder, and simultaneously rotate the baby through the pelvis. You're going to have 2 fingers behind the anterior shoulder and 2 fingers in front of the posterior shoulder like this, and you're attempting to do the reverse Woods. In this case, you put 2 fingers anterior to the anterior shoulder, 2 fingers posterior to the posterior shoulder, and again attempt to rotate the baby through, but in the opposite direction, as such. So for that maneuver, you'll have 2 fingers anterior to the anterior shoulder, 2 fingers posterior to the posterior shoulder, as such, and then again you're attempting to rotate. Remove the arm. With that, you place your hand in underneath the baby. Run your fingers along the baby's humerus. Once your fingers get down to the antecubital fossa, and you press on it, the arm will flex forward, the elbow. You can then grasp the forearm and either pull straight out or try to sweep it across the baby's chest and rotate the baby out. So to demonstrate, you run your fingers along the baby's arm. Once you reach the antecubital fossa, the forearm should flex up. You then grasp the forearm and either pull straight out or sweep it across the baby's chest, rotating the baby up. Roll the patient onto all fours. You then do the exact same type of maneuvers as you would do if the woman was on her back.
All right. So then, very briefly, we're going to talk about the 2 other complicated types of deliveries. One is a breech presentation. They've got, 3 different types, which is the frank breech, which is essentially a pike position. Both hips are flexed and their knees are extended straight up. Then the complete breech has both hips flexed, but the knees are also flexed. And then there's the incomplete breech with the foot sticking out, and it's defined by just having only one of the hips fully flexed. Now, the most important point that I want to make about a breech delivery is really just to allow spontaneous labor and delivery. Support the baby's body after the cord appears, okay? Whether it's a footling or the butt coming out, avoid pulling on the baby and just allow spontaneous labor to happen. And then the third complicated type of delivery is the prolapsed umbilical cord. And once again, just really boiling it down to the most important point. keep pressure off the cord. Okay, keep pressure off the cord. The most recommended position for the mom is the knee chest position. And this naturally will help keep pressure off the cord. But one of the ways that you may have to resort to is the provider may have to put his or her hand in the birth canal and just lift the baby's head off or to the side of the cord just to make sure there's no pressure on this umbilical cord until you are able to get to the delivery suite to have the C-section. It's recommended that the prolapsed cord baby have a C-section delivery. So what happened to my case? I bet you're wondering what happened to my case. So after I realized that her water hadn't broken, I just called everybody I could. So I called the OB. I called a high-risk OB. And we fortunately was able to get her transported to a nearby hospital, only about 10, 15 minutes away, because we don't have OB services, right? So when she got there, they actually did a formal ultrasound, and she was 34 weeks. Thank God. She was 34 weeks. They delivered her about 2 hours later, and it was a 5-pound baby boy. So it went very well, fortunately, And I kept saying afterwards, I said, the only thing that saved this baby and this woman is that her water didn't break. And it would have been a whole different story if she really had a precipitous delivery there in my emergency department. So I was grateful that it turned out the way it did.
Yeah, if her water would have broken with previous deliveries, you worry about, how quickly she's going to deliver and whether that's a good idea to transfer them to another facility till that delivery happens. So.
One upside is, with a little bit early, a little bit premature, is usually the delivery itself goes very smoothly. If the head is down, it's usually a super easy delivery because the baby's on the small side. It kind of just slides right out. And then you focus then on the neonatal resuscitation piece of it because that can be a little bit more difficult. And actually, we recently spoke about this on Rebel Corecast with one of my chief residents, a neonatal delivery that she had, and how the delivery itself was super easy. And even though the membranes are intact, sometimes the delivery is still precipitous, right? I mean, sometimes that baby's still coming out. The parts of the amniotic sac are herniating. And so in their case, they thought that delivery was happening right away. And so they actually made a small cut to open the amniotic sac. So you sometimes do have to do that. So the intactness, I just don't want anyone to get too reassured. If the cervix is effaced and dilated, but the sac is intact, that doesn't necessarily mean you can send them on a 90-minute transfer. You're still going to want to think about, maybe I have to deliver this baby before they get into that ambulance, because you really don't want your medics to have to do it. And your medics don't really want to do it either. They want some more backup.
Right. Those are excellent points. I have said this so many times over these multiple months, but I've said I'm so grateful that the case didn't turn out to be more difficult than it actually was. But I thought that this was an important case to talk about and have you guys help me teach because it's a rare event. Like you said, Sal, it's a rare procedure that we may have to go through, and it's always great to review these things and practice them. So thank you so much, you guys, for joining me today. And I look forward to another recording with you guys. Thank you so much.
Thanks for having us.
All right.
Thanks for having us. This is great.
Thank you. All right, folks, thank you so much for watching this month. I hope everybody is still COVID-free right now, okay? All right, we'll see you next month. Bye-bye. Bye, you guys.
Bye.